Broadcast of late life Atul Gawande is made possible by Allina Health's Life Course Project, the Minnesota Network of Hospice and Palliative Care, and Twin Cities PBS. Life Course is funded by the Robina Foundation.
I learned about a lot of things in medical school, but dying was not one of them. And I went into medicine to learn how to fix. I still did not, after more than a decade in practice, feel competent in knowing what to do when I couldn't fix. And I would find myself doing surgery in situations that I knew had very little, if any, chance, and most likely was going to make people worse.
And didn't you say that to the patient or their family? Or how did you?
I didn't know how quite. If you say, well, you have a 100% chance of dying, and maybe you have a 98% chance of dying if we try something. And so isn't it worth that 1 or 2% chance? Do you want it or do you not? And inevitably people say, well, yeah, I'd want it. Even though I might then say, well, there's a big chance that something goes wrong and that things could be worse. I'd misunderstood my job. And that's the way in which I felt we were failing, was I didn't know what my job really was.
What was the epiphany? Was there a moment where that became very clear to you?
It wasn't an epiphany. In fact, the process of writing about it was, I often write about the problems that I'm most confused about. What should we do about the costs of healthcare? How do I understand the mistakes I make and my responsibilities? I wrote a piece about why do we itch?
I remember that.
And this one was how do we do better? How do I do better along the way? I, in fact, had written about it in certain cases from the very beginning of my writing and never came to good answers. And this time when I approached it, I just started interviewing people about their experiences, families and patients about their experiences with serious illness and serious infirmities, and learning what their experiences were, what they were going through. And then I began interviewing people that have been on the peripheries of medicine, palliative care physicians, geriatricians. I talk about, there was a geriatrics clinic 1 floor below mine in surgery. It's been there more than a decade. I never once set foot in there. I had no idea what they did. And so, the wonderful thing about writing is you get to say, well, I'm writing this article or I'm writing this book. Would you let me follow you around? You can't normally say that to people. But if you're writing about something, you have an excuse. And so I hung out in the geriatrics clinic. I really didn't know what hospice was. To me, hospice was a black hooded nurse with an IV morphine drip coming to send you to the great beyond. And then I went traveling with an IV, with a
That was interesting.
Yeah, with the hospice nurse to visit people. And it was an amazing experience. I remember we visited Lee Cox, who had congestive heart failure. She had, oxygen tubing that she trailed, 50-foot long oxygen tubing so she could go all the way around her house. 72 years old, congestive heart failure, been in and out of the hospital, and she was very upset and sad when her doctor suggested hospice because she felt he was just saying, this is the end, this is all you get. And they thought she had weeks to live, and at best. The hospitalizations were just increasing, getting worse. And that day we went in, and the nurse, her name was Sarah, came in and said, "Hi, Lee, how are you doing?" And she said, "Not good." So what's the matter? And she said, she was having trouble breathing. She couldn't go 5 feet without having real shortness of breath. And then suddenly Sarah went to work, and she was listening to her lungs, figuring out what's going on. She went and inspected the oxygen delivery system. That was okay. She figured out the nebulizer was broken and not delivering properly, and that she hadn't been taking her medicines, and then maybe some medicines needed to be changed to help with her breathing. And she started getting this flurry of activity. And when we're all done and we got outside afterwards, I said, "I thought your job was to let nature take its course. I thought that's what you did." She said, "No." She said, "Medicine sacrifices your time now for the sake of time later. But I think my job is to give you your best possible day now. We're both using the medical capabilities, but it's for different purposes. And that was when I finally understood what she was doing and what you all are doing in hospice and palliative care. You're just trying to give people their best possible day now, no matter what happens tomorrow. And the amazing thing is then I went to the data and looked it up. And it's almost Zen. By not worrying about what comes in the future, people did not live shorter on hospice. On average, they lived longer. Lee Cox had been on hospice for 11 months. And in fact, the debate was, should she still be on? Mm-hmm. She hadn't been in the hospital in 11 months. She was doing far better. She was happier. She had less suffering in her life. She was having the best possible day that there could be found each day.
Where do you think the misconceptions around hospice come from? And I say that because Dr. Benson was kind enough to mention my friend Bruce Kramer. And I remember Bruce I remember when he told me I'm going into hospice, and I said, oh, are you dying? And he said, yeah, I have ALS, and I've been dying all along. He was in hospice for about 7-8 months. But I had misconceptions of what hospice was, and he explained it to me. So it sounds like,
how did he explain it?
Pretty much exactly what you said. And it really freed him to live the rest of his life, right? Without worrying about treatment. And I'm wondering, as a physician, a young physician, did you have misconceptions or preconceptions?
I'm glad you still think I'm young.
Yeah. You look great. So, what were your misconceptions or preconceptions as a young doctor when you're going through med school, or wasn't it even really talked about?
Well, the first misconception is that death is a failure. And that's probably the most central thing. I'm a surgeon, and the idea is that you gear up for battle and death is the enemy. I didn't know how to think of it as otherwise, but there's a certain point where you're General Custer and going to battle against death every day to the point of annihilation is failure. That's the failure. And I only came to understand that after many years, and then finally thinking through and trying to understand what these other people were trying to say and articulate. And it was very hard because, you go around and talk to palliative care doctors and you get them to explain, or hospice providers, get them to explain what they think I should do differently next week and what their work really means. And you all disagree with each other. Like, you do not seem to think that anybody else does better than you do. And so everybody says, don't listen to those people. This is what it really is. But in fact, all of you were saying, for me as an outsider, the surgeon coming in, listening to you all, it was some very basic things. It was about the best possible day today. It's about giving therapy and capability and using our best medical capability towards those kinds of goals. And then you realize we're not asking those questions well before death. Forget death. When you just start needing help, shouldn't we be asking what your priorities and goals are that matter the most? And are we actually helping them along the way? And to my surprise, I ended up writing 2/3 of the book about something I'd never thought about, which was elder care and housing. But when I contrasted what my grandfather's life was like dying in an Indian village surrounded by family with no health care at 108, and the last 20 years of his life surrounded by family with my wife's grandmother in Alexandria, Virginia, living the last 25 years of her life as a widow, independently, loving her independent life, but then the last 2 years in a nursing home, miserable. I suddenly realized we weren't asking her, and my great regret was we never did ask what were the most important things to her that she wanted as she faced her health worsening. And so I think the core of the sense of the failure, I think, is, okay, if death is not a failure, what does that mean? And you put up that quote from the book, but that was the revelation to me. we have this intense debate, highly politicized debate over death. And it feels like all sides are getting the question wrong. It's not about a good death, it's about a good life all the way to the very end and how we make that possible. And we'll be hugely divided over these issues of assisted death and so on. But, people in India are having a debate about assisted death. And in India, I'm visiting places where you see that you can't get pain medicine. Well, if you have cancer and you're in severe pain and no one is providing narcotics to you, and you talk about, well, would you want to have the option of controlling your death? Well, yes, of course. But what you really want is some pain medicine. And that's the transformation that we're still slow to come to.
I'm curious about this. The Centers for, as you know, Medicare and Medicaid is expected to make a decision maybe by November 1st of this year to reimburse doctors and other medical professionals for having end-of-life planning discussions with patients, which is great news, but don't you have to make sure that those that are having the conversations are well trained? I can see it's fine if you're going to be reimbursed and check off a box and say, I've done this, but don't you have to be pretty well prepared to have these conversations without making your patients incredibly nervous?
Yeah, there's an assumption behind it that we know what a conversation is, what a good conversation is. And as I said, I hadn't really been taught along the way, and I was trying to, and there wasn't an obvious place to turn to help distill what the basics really are. It takes years to become great at what you do as hospice and palliative care specialists. The studies show that the most powerful study to me was a randomized trial of lung cancer patients who had stage 4 lung cancer, so terminal lung cancer, that they lived on average 11 months. And they, at the Mass General Hospital in Boston, they randomized that half of them got the usual oncology care, and the other half, long before they were really sick with it, right from the very beginning of diagnosis, they got palliative care consultations, where they would have discussions about the future with the disease. And the people who saw the palliative care specialists ended up having, later, they would come to the end, and they would receive, they ended up choosing to stop their chemotherapy sooner, much less likely to go to the 3rd or 4th round of chemotherapy. They were less likely to have surgery at the end. They were less likely to be in the ICU, less likely to die in the hospital. They started hospice care sooner. They had less suffering at the end of life, 30% lower costs. But the kicker was they lived 25% longer. And so your options are, well then, everybody should get a palliative care specialist. And, you all are reaching, palliative care specialists are reaching less than 5% of people at risk of dying at that early stage. So our options are, well, do we have 20 times as many trained and then we outsource to all of the palliative care folks? Or do we recognize these are basic skills that every clinician needs? And if we did that, then what I was doing in the course of writing the book was really trying to capture what was it that they were doing and how can we pull that out? And the conclusion that I came to was that the one thing that they all had in common, they each described something different that they were doing, but the one thing they had in common is they were having a conversation about the priorities that mattered most to people besides living longer. And that's a conversation we have less than 1/3 of the time when people come to death. It's just 7 questions that they basically ask. It's like a menu. Ideally, you ask all of them. And they're ones like, what's your understanding of where you are with your health or your illness at this time? I'm used to just giving the facts. This is where you are with your health. This is your prognosis, this is your median survival, da-da-da-da-da. This is, put it in your own words. What is it to you? And then, what are your fears and worries if your health worsens in your future? What are your fears and worries for your health overall? What are your goals and priorities if time is short? What are you willing to go through and what are you not willing to go through for the sake of more possible time? Who will make decisions if you can't because 70% of us will come to the end with somebody else having to make those decisions. And have you told them your answers to these questions? And that feels like the thing I never learned that I wish we could have learned. And then once I realized that, I wished I knew that as a family member, because those aren't questions that only a doctor can ask. And when my dad was diagnosed with a brainstem astrocytoma, a malignant tumor in his brainstem and spinal cord, he was a surgeon, I got to ask him those questions and find those answers.
How did he
and it
react
transformed
to
his
that?
care.
How did he react to that? As your father, yes, but as a physician as well.
Yeah. You know, it's funny, I describe in the book what it was like. You know, he called up one day, and he's a surgeon, I'm a surgeon. He said, I had an MRI, and you know, I just emailed you the images. So I open up on my computer, he opens them up on his computer, and there's this big tumor in his brain. And we're just staring at it. And so we're trying to think of everything it could be besides a brain tumor. And then once we're like, well, okay, suppose it's a brain tumor, then we're talking about, like, how would you get that out? I'm a general surgeon, he's a urologist, we had no, like... But we're like, I don't know how you get that thing out. And, you know, we were not coming to that conversation. It took a while. It was about a year later that we finally had the conversation. And I just asked him, I said, what's your understanding of where you are with this? And he said, this thing's going to kill me. I didn't realize he knew that, and he was thinking that. He was well ahead of where I was. My mom,
she's a physician as well.
She's a pediatrician, but she was not happy to hear him thinking that way. She said, you know, you don't know that. He said, I do. But he said, I don't know when. I don't know when it could happen. I mean, you know, it could grow very slowly. It had hardly moved in a year. He said, it could be a decade, I don't know. And then I said, you know, what are your fears for the future? And he said his fear was losing his surgical practice. He wanted to be a surgeon that was the only identity he knew. And so for a long time, the treatment ended up being, that was an incredible guide. It was like the best living will. You know, as long as he could keep that going, that was important. But then when he couldn't do it anymore, then, you know, we had the conversation again. So now, what are your fears and worries? What are your priorities? And I talked about with him a colleague of mine who talked to her father, who had, oddly enough, had a spinal cord tumor and was becoming quadriplegic. My father was becoming paralyzed in his arms and couldn't operate anymore. And my friend's father said to her that he was willing to give up a lot as long as he could eat chocolate ice cream and watch football on television. So I said, that's what they said. And he said, no way is that good enough for me. What he found he loved was just being at the dinner. He was a very social person, just being with people, being at the dinner table, talking to family and friends. You know, he was a guy who always had people over at our house 3-4 nights a week. That was joy for him. And as long as he could do that, even one day a week, that was what he was willing to live for. That was what he wanted medicine to save him for. And that became our goal. And it was, you know, we went through a radical operation. He went through the radical operation. I went through watching him go through the radical operation, that a spinal cord procedure that's fused his spine from the base of his skull to the middle of his back, opened up space so the tumor could grow without paralyzing him more. And that provided another 6 to 9 months of time he could still walk. And then when he couldn't walk, he could still get to the table, and he needed help being fed, but he could still do those things he wanted until the pain reached a point where we tried radiation and it only made matters worse. And then chemotherapy was just making him miserable, and it kept him from being able to get to that dinner table. And so then he went on hospice. And that conversation was the guide the whole way. And we kept on having it right to the very last week of his life.
I'm glad you did. I thought it was interesting reading the book as you and your family and your father were going through the process at the beginning, as you were trying to figure out what to do, that you knew how to ask the right questions, obviously, of the surgeons and the oncologists. What surprised me was how doctors overestimate how much time a patient has, or overestimates the situation. That just really, boy, that came as a bit of a shock. And I guess I'm curious as to
why did that come as a shock?
because I thought doctors would be more honest about the situation.
I think we're being on. The funny thing is,
Sorry.
I think. Yeah. No, I think it's two things. Number one is 40% of oncologists acknowledge giving treatments that they know will not work. And so 40% are acknowledging it. So you're right about the honesty question. But I think there's also a fundamental optimism that we all have, and confidence in ourselves and the way we do the work. And we're more likely to be wrong the better we know our patients. That was another surprise in the data for me, that the more we know our patients, the more likely we are to be wrong. And it's wrong in both directions, overestimating and underestimating. But in general, we overestimate how much time people have. That we were tending to estimate by 500% for people in the last 6 months of life, how long they had.
What's behind that? I'm curious.
Optimism, belief in your capabilities, feeling you know this person, and also I'm not sure we see the whole story. There's a certain point where we're missing from the elements of what people are going through and what happens along the way. So, there are many things. We all have anxiety. Everybody has anxiety about death. We all have anxiety about talking about death or just, the uncertainty of what's to come. And I'd say another thing is that our biggest fear is being wrong in the short direction. We've all had the patient who said, you said I wouldn't live 6 months, and I'm here, I had an 82-year-old woman when I was a resident who came in. She had a known aneurysm of her abdominal aorta, and it was huge. It was 3 times bigger. You could feel it throbbing in her belly, and she'd been recently diagnosed with it. It was, and she came in with an abdominal pain that indicated it was rupturing, and we got it scanned, and there was this rim of fluid around it, and indicating there was blood leaking, and this is a rupturing aorta. Impending rupture with the abdominal pain and everything indicating it. And so I sat and discussed it with her, got the vascular surgeon in, and we sat down and we said, you have a 100% chance of dying unless we go to the operating room and try to save you. And but on the other hand, this is a huge aneurysm. It goes above your kidneys, and you would have she was living alone in an apartment above her son, and she was living a independent life, and we say it's very unlikely you would get to go back to that life because this is a pretty big operation. And you had a very high chance of being on dialysis as well, because we have to unplug the kidneys and then plug it back in to the new aorta we would put in. And she said, she wanted to think about it. We said, okay, you have 15 minutes.
Oh.
And we came back and she said, I've been already counting my days in coffee spoons. I've written my will. I just want to go home. So I did something I'd never done. I wrote a prescription for pain medicine. We called to arrange the hospice. Watched her go out the door on the arm of her son. And I waited a couple weeks to see the aftermath, because this was going to be a matter of, I was worried whether she'd even get home. Matter of days, probably. I called a couple weeks later, and I kept the son's phone number so I could catch up with him about the aftermath. And I called his home, and she picked up the phone. And I sort of stammered, how's it going? And she said, fine, doctor, how are things with you? And I kept up with her for a year, and she I don't know what happened. But you get these things wrong. And in both directions. And dealing with that uncertainty, we say 25% of spending in Medicare is in the last year of a person's life, most of that in the last 2 months. Your most likely week to get surgery is your last week of your life, the week you're least likely to get any benefit. And if I knew when that week was, it would be a lot easier. So dealing with the uncertainty, it's really these tools and ways of thinking about it by asking people simply, what is a good day today? What matters to you most? And living with the uncertainty. And just asking, how much do you want to sacrifice your time today for the possible time tomorrow versus just having a good day today? And that has been a total revelation for me. And I think is the kind of revelation that we're just now getting our brains around, let alone beginning to be able to teach it.
Speaking of teaching, I have a tweet here from Steph Trudeau. I'm thinking she may be a med school student. Steph wants to know, how do we teach med students, residents, to become comfortable with having these conversations with patients and family?
Well, there's a chicken and the egg problem, which is that you need someone to teach you. And if we haven't all learned these skills very well, I think one of the things is that a fascinating thing is that palliative care and geriatrics and hospice are specialties that have generally not been invited into the medical school world, and they're suddenly getting invited in. That people need to see these, need to go on these rotations and have these experiences. I did not have a geriatrics rotation, and most places don't. Did not rotate on a hospice service, to not see these things. And now these kinds of expertises are being invited in, but it also needs to be taught and modeled that you need to know, you need to be trained by surgeons and critical care doctors and oncologists and others who have these skills in their skill set and have it as part of what they do. And we're just now beginning to deploy that capability at the senior levels as well. But I would say the most important thing for people in this world is go hang out with these guys for a month. I just did it for a few days and it changed a lot.
Another tweet here from Nathan. So, what are the main barriers to having these important end-of-life conversations?
Oh, only everything. On the patient and family side, the anxiety about death, the fear that you're abandoning hope by discussing not just hoping for the best, but how to prepare for the worst. Disagreement in the family about what's going on.
Very difficult.
A colleague of mine called it the seagull syndrome. The family gathers around and the family member from farthest away flies in and craps all over the plan.
I will remember that.
So there's that. And then on the clinician side, discomfort. We're paid far better to do the operation than to take the time for the conversation to plan whether it's the right thing to do. We're uncomfortable with that conversation and very comfortable with doing the operation. We're not used to somebody crying in our office. We think that's failure. There's a certain kind of, I'm still learning how to manage the different kinds of flavors of denial and patience and the different kinds of family conflict. And it's the recognition that, that's when you need the palliative care and hospice folks to provide the expertise, is that, you do get these very difficult cases of people who are in total denial and that you're actually likely to harm them by really pushing on these issues and lose their trust and need help and expertise along the way coming in from the side that and acknowledging that, when you feel like I've talked to hundreds of people who've faced death. I know what I'm doing. So there's many layers along the way. we're unpeeling it, and there's a dramatic change going on, and I think we can miss how much is changing. 1950s, the majority of Americans died in their home. Because going to the hospital, there wasn't very many options. There wasn't much that could be offered to be done for many illnesses. Now we can offer a lot, and by the late 1980s, early 1990s, it had completely flipped. We were at the point where 80% died in institutions rather than homes, and it had become this heavily medicalized experience. In the last 5 years of this incredible acceleration, we're now closing in about half of us dying in hospice. Too late, the most common thing being people saying, "I wish I'd discovered you sooner." And that's starting to change. But I grew up with no experience of people going through frailty and serious infirmity and then the dying process in my neighborhood. I never saw anybody who died until I was a medical student. And every one of my kids have been at the bedside of people who've died in the neighborhood because they died at home in hospice. I wrote the story of my daughter and her piano teacher dying and getting piano lessons while she was still on hospice, and having a recital the 2 weeks before Peg, her teacher, died. And my daughter and son have been there with friends when their grandparents or family died. And it's affected them deeply. It's become more of a normal part of their life. We've not hidden it away. And I think we can forget how much is already changing.
Have you thought about your mortality? I presume you have. You know, you're at the bedside of patients who are dying. You try to sustain life as a surgeon, but have you deeply thought about how you want things to work out? What are you most afraid of?
Well, the funny thing is, the last place I think about it is at the hospital. Because I don't picture myself on the other side of that curtain or the other side of the table. But in the course of thinking about it later with my patients, my family, I've thought about a lot, and then thought about these questions, and my wife and I have ended up talking about it, and we totally disagree. So from my point of view, I would be willing to be Stephen Hawking. That as long as my brain could work and I could communicate with people and I could have interaction and ideas, you know, I could even be reduced to a brain in a jar. And as long as it could work and I could, you know, beep, beep, beep with you, that would be okay. And my wife says, "That's a stupid idea." She said, "Why is it important that, you know, we know who you are and you know who we are and connect and all of those kinds of things?" She said, you know, she's more religious than I am. She said, "I'm God's creature. And as long as I look happy," and you know what I look like when I'm happy and when I'm not happy. "I don't care if I don't know who you are or anything like that. If I look happy, keep me going. And if I don't look happy, don't."
Okay.
My only worry is I tell her that, you know, I've signed my organ donor card, and so I said, "You've got to donate my organs." And she said, "Maybe."
Because doctors are human and have the same frailties as the rest of us and foibles and fears, I bet a good many physicians are also afraid of dying. Are you?
Absolutely.
Okay.
But I have to say, I wrote about the story of Lou Sanders in the book, he's 94 now, and he, a World War II veteran, he never got anything more than a high school education. He had a business selling appliances and then got beat out by, you know, Best Buy and the latest big box store. And as he and his wife then died and he became widowed, but he was happy as long as he could live independently. And then he started having falls, and his memory problems started to appear. And then he moved in with his daughter, and then she was just in misery because she's trying to hold down a job and take care of him, and he was having even more falls at home, and she felt she couldn't handle it. And feeling guilty, she nonetheless took him to an assisted living where he was tremendously unhappy. And then he ultimately escalated into a nursing home. But then he was lucky enough to be in a pioneering nursing home, a greenhouse by a guy named Bill Thomas I wrote about. Bill is he calls himself a nursing home abolitionist. And he's built places that are, nursing homes look increasingly like hospitals. They're built around a nursing station. And you have, shared rooms with, someone else who's hopefully as demented as you are. And people are miserable about, why, because I'm in a wheelchair, do I not get to have a purpose in life? Why does it mean I can't have some autonomy? And so he built it around it. He built places, not a giant hallway with 60 people on it, but in a circle of no more than 12 people in private rooms, built around a kitchen. And by the way, built these in ways that they could get by on Medicaid level reimbursements. And in the kitchen would be a refrigerator, and you could go in the refrigerator anytime and eat whatever you wanted. And do you know how controversial that was?
I bet it was very controversial.
A diabetic can go in the refrigerator and take out a soda? Well, this is their home. Why couldn't they? Well, it would be a mistake. It might be unhealthy. It'd be unsafe. True. But can we negotiate ways that we can actually give people choices, the way they live in their own home? And he's managed to do that, even with the regulations. Let people have pets that they help care for, even people with dementia where they can't completely take care of the pet themselves, but they can be part of the care of the pets of their own. Have something to care for that's beyond themselves. They start to have purpose and live on in that way. And Lou got to live in one of these places. And I saw somebody who, at 94, with a walker, and has got the tennis balls on the front ends of the walker, difficulties with his memory. And I got to see somebody who was happy and felt he had a reason to wake up every day. And it was the first time I was not afraid. I think we're incredibly lucky to get to live to be old and frail. We're all gonna, if we're lucky, get to go through that part in our life. And we live in an era where that capability is now open to the vast majority of us, where in many cases you just would have dropped dead before your time. And that means learning how we make that phase of life something valuable and worthwhile. And the last thing I'll say about it, I know I'm going on and on, is that, I wrote at length about a psychologist at Stanford, Laura Carstensen, who'd studied people as they aged, and what she's shown is that people as they get older are happier than they were when they were younger. She's followed them for many years of their lives. Levels of anxiety and depression go down as long as we don't take away autonomy. It's when they're institutionalized that we've taken away freedom. And I can guarantee the baby boomers may have let their parents be in this situation. One of the nursing home administrators said, "Safety is what we want for those we love, but autonomy is what we want for ourselves." And if the baby boomers reinvented childbirth, I'm pretty sure you're going to reinvent what happens at the in that last phase of life, and we'll be designing what a good life means. And one thing it'll mean is that you get to have that refrigerator, and you get to have a beer at the end of the day. And as Bill Maher asked me when I got to be on his show, he was like, "Do I get my porn?" Oh God, I don't know.
See, as we're talking about reinventing our system, I'm curious about this. We're talking about a system, though, Doctor, that is powerful and lucrative right? I mean, it involves hundreds of billions of dollars. And it's built, though, to repair and cure still, right? And having talks about Medicare reimbursement and filling out forms is fine, but how do you really slow the gears of a medical system and really try to begin positive change?
You know, I've been completely flabbergasted by the response to the book. So one level is that people both inside and outside medicine resonate with the desire that we are building systems that help people achieve not just length of life, but quality of life. And for people in healthcare, there's a lot that makes you feel that the purpose of your daily life is being drained by, becoming a data entry clerk for my electronic medical record, and the sense that I'm losing touch with the patient and what the goals are along the way. And being able to be good at identifying what is the priority for you, in addition to living as long as you might want. And how can I help you maximize that is reintroducing. I never expected that I would be as gratified being able to take care of people with problems I couldn't fix as I am with people who have problems I can fix. And I think that there's a sense in which just at that, before the economics ever get in there is a resonance. Many of you who went into hospice and palliative care had been through all the different parts of medicine. And you're those weird people who go through more training in order to make less money. And it's the same with geriatrics. But there is so much purpose that you are able to grasp, and I think people are awakening to that. The second part of it is the economics is changing. And we are, right now, under the ACA, it introduced different models of payment besides just paying you for every pill and procedure you produce, but changing to identify that you're responsible for an entire budget of care and about quality of life and quality of care that people have, and we're working on getting the definitions to include what quality of life means. But that has meant that people are getting to reinvent primary care, and innovation around bringing that back in is a major force in people's lives. And that we're now at a point where, as of this year, we're at 20% of the American population in Medicare are now in a world where their doctor is not paid the way we used to pay them. Their clinicians are paid for the value of what they provide. And that is starting to head into a tipping point where there is dramatic change. We have clinicians who now, I wrote about in the most recent New Yorker, that even in McAllen, Texas, the most expensive county for healthcare in the country, there's been a dramatic turnaround in the last 5 years with introduction of vastly growing primary care, accountable care organizations that are wrapping around people to keep them out of the hospital and keep them out of emergency rooms where unnecessary. And they're bringing in hospice. It's a fascinating measure that people at Dartmouth came up with. It's the ambulance to hospice ratio in the last 6 months of life. And in parts of the country like Minnesota and Oregon, the hospices are far more than the ambulances. And in McAllen, it was the other way around, and it's already shifted to the point that people are getting better care or more satisfied with the care. And they've saved $500 million in the last 5 years since I last wrote about them, and they were getting all too much attention about the costs of care that they were facing. So I think the economics is lining up and starting to change, but I think that it comes first from what we think the goal is, and that families and clinicians are pointing in the same direction about what we want and demand from the system. And then that leads people like Senator Franken to get all kinds of pressure to change some ways that payment gets done.
I have a question from cleverly on a napkin, by the way, that was given to me before I got
Delivered
on stage
through
here.
Twitter.
Yeah, no, actually, no, it's from an MDA, Dr. John Moracek from Abbott Northwestern. He's an anesthesiologist. How do we empower our patients to help them help us surrender our pursuit of life salvaging, to partner and have families pursue a dignified and rewarding and fulfilling conclusion?
One of the fascinating things to me about the Mass General Hospital study I told you about, where people got early palliative care conversations compared to the ones who didn't, was that 25% longer survival as well as less suffering at the end of life. So you had the conversation. So then did the palliative care doctor, were they then swooping in on the Saturday night when you turned up in the emergency room short of breath? And the choices suddenly had to be made. No. It's hard to get a palliative care doctor on the phone on a Saturday night often. And it wasn't like the notes were put into the electronic system and flashed up on the screen and said, here are the priorities of this patient. The most powerful thing that happened was that the conversation led the patient themselves, just the conversation asking them to put in their own words, their fears, their worries, their goals, their understanding of where they are, led them to become the actor. That they were the ones drawing the line, saying, this has gone too far and is taking away things that are important to me, and that it empowered them in ways that nobody expected. And that second, they were having conversations more often with their families that told them what their wishes were. And that was without even planning it very carefully. And then yes, the third was when there was communication between the clinicians about this. But it wasn't because the doctors then started swooping in and doing it all. I think it's important that we figure out where we put the information about what matters to you most and who your healthcare proxy is and what you've communicated to them about what matters to you most in the system where we can find it and it's readily found. But I think the empowerment comes from making these conversations normal. Here's the most important thing you can do. Yes, you should have these conversations at any time. But if you ask if there's someone in your life that you wouldn't be surprised if they died in the next year, what we know is those people are at very high risk of dying. And those are people you might ask, what's your understanding of where you are with your health? What are your fears and worries for the future with your health? What are your goals and priorities? What would you be willing to go through and not willing to go through? I want to know because I want to know what matters to you most so that I can help you along the way. And sometimes people aren't ready for it. And you just start with that first question and they're like, what is this about? And then there'll be another time. It's a process, it's not an epiphany. It's not like one magic moment and suddenly people completely shift their understanding. But that conversation activates all of us. And I think that to me is the transformation that all of us as clinicians and family members can initiate.
Another good question here from Twitter. This is from Olivia Houston. Olivia wants to know, how, doctor, would you define the role of a physician with your new understanding of palliative care?
In the 1950s, we thought the role of the physician was what I call doctor knows best. And we didn't necessarily tell you what your diagnosis was. In fact, we thought telling you your diagnosis would kill you. You'd lose all hope. And so we often didn't even necessarily even tell you your options. We just said, this is what we're going to do, and expect you to. And in the 70s and 80s, people really rebelled against that. They said, I need to know. I want all the information, and I want the control over the choice. And so, as I was trained in the 90s about what it meant to be a doctor, it is the model that I've come to call doctor informative, that I provide lots of information, that, here's how you're doing and what I understand is your prognosis. Here's your options, option A, option B, option C. It's like, and then you tell me what you want. It's like being a shoe salesman. Here are the red shoes and here are the blue shoes. Which one do you want? Do you want the red pill or the blue pill? And then what I found in practice was that people would then say to me, gosh, I don't know, doctor, which one would you take? And then I was taught to say, it's not really for me to decide. It's really you and your values, and you're the one to make this decision. And I always felt like people were kind of abandoned in that situation. And what I came to understand is that, what we've come to call shared decision making, but to me, it's easier to understand that my role is to be a counselor, to be good at learning from you what matters to you most, what your goals, what your priorities, what your values are. And then, yes, tell you the options, but make a recommendation based on what you're telling me. I was kind of afraid to make recommendations, frankly. But, you only get to go through this kind of illness. You only die once. And I get to actually have seen enough people go through it to have some idea of what the options really mean. And if you tell me that, eating chocolate ice cream and watching football on television is what you find to be a life worth living still, then I can tell you what's more likely to get there and what's less likely to. And I think that is the transformative role, that we learn to become good counselors in a way that we've hesitantly embraced.
You mentioned the word transformative. You've been on an interesting journey yourself, haven't you? How have you been transformed by your work?
I feel competent at having these conversations. I had a cousin up in New Hampshire on my wife's side of the family who they had a daughter who was 14 years old and had a lymphoma that was treated at age 12, and it was successfully treated, a Hodgkin's lymphoma. We have very good treatments, 80% survival rates, but the 20% it does come back. And it came back in her, and then they tried a second round of chemotherapy and a third round of chemotherapy. She had complications, and then she'd been 3 months in the hospital, and chest tubes in both sides, and a catheter in her belly, draining fluid accumulating there. And then the next option was a experimental bone marrow transplant or going home on hospice. And they called to ask me what to do, what they should do. They were agonizing. And this was before I'd written the book, and I wrote about it in a previous book. And I didn't know what to say. I was doctor informative. Well, here's my understanding about where you are, and what this illness is, and what the experimental therapy is. And I had you have 100% of dying on one side, and then maybe 95% on the other. But who knows? Maybe there's a chance. It was really unhelpful. And I came off that conversation with Robin and Shelley, her parents, feeling I'd not helped them at all and that they were still in the wilderness. And they sent me an email along with all the rest of the family about a week later saying they decided to take her home, to take Callie home. And then a week after that she'd passed peacefully, that she died peacefully. And I now know what to say. And I wish I'd known that. And I feel competent enough now to just ask them, what's your understanding? I know what they would have said. They would have said, yeah, we know she's dying. And their biggest fear was that she would die her last days in that hospital room, isolated, with gowns and gloves, and no people that she knows, no chance to say goodbye, no chance to connect with her classmates and all those things. And on their own, they just decided that's what we're going to make happen. They didn't know if it was the right thing to do. And I could have said it was the right thing to do, and they wouldn't have gone with heavy heart, but with joy. And I think that is, I regret that, but I know I can do that now. And I know that all of you can too.
You feel competent, but also do you feel like you're a more human physician? You bring more of your humanity to your job as a physician?
Yeah, well, I mean, do I feel more human? Well, I always felt I was human.
Sure.
And that, it was a struggle and I wasn't doing very well with it. And I think I felt like a more competent human being. I felt I was more humane, that I was becoming more humane. Yeah.
Dr. Atul Gawande, I wish we had more time because there's so many things to ask you about, but thank you for being here.
Thank you.
Broadcast of Late Life Atul Gawande is made possible by Allina Health's Life Course Project, the Minnesota Network of Hospice and Palliative Care, and Twin Cities PBS. Life Course is funded by the Robina Foundation.